By producing a patella alt or patella bhaja. So you always check for the Varus, you need to check for the laxity of the lateral collateral ligament. So if the lateral collateral ligament naturally will be lax, so take less cuts. And in the end, reconstruction of bone is also very important. That's what we are going to talk about in this topic, that is the defects management. So these are the important things to be noted down while we address the defects in the bones, either on the tibial side or the femoral side. Usually on the tibial side only. In the femoral side, usually when there is a flexion deformity or the recurvatum only, you will see the femoral defects. In the recurvatum, you will have the defect in the distal femur, or in the flexion deformity, you will have the defects in the posterior condyles of the femur. And all the rest of the defects will be the tibia only in the severe varus situations. So that's what I was telling you in the classifications. So how to address the bone defect. So never ever chase the bone defect. So take a minimum cut and then try to address, don't hide the bone defect. You have to address it. You can't chase it. That is the important message here. So what to be done to cover the bone defect? So we have bone cementing technique, bone cement with the screw, or bone graft with screw, metallic wedges, and recently we have with us the metaphyseal sleeve or the cone technique. And if the metaphyseal defect is more than 15 mm or so, definitely we need to bypass it by using the megaprosthesis. So this is the, usually we don't come across femoral bone loss yet, we need to talk about it. So in the femur, the most important thing to be noted down is assess the integrity of the epicondyles. So your management depends on whether the epicondyle is intact or not. If the epicondyle is intact and it is not affected, and if the defect is less than 10 centimeters, you can as well manage with cement and the screws. Or sometimes you can as well get away by just doing the grafting or metal augments depending on the size of the defect, as I told you earlier. If the defect is more than 10 mm, and with marked metaphyseal bone loss, it is 10 mm, not 10 cm, it was a mistake. So more than 10 mm, definitely we need to have a metaphyseal sleeve or cone technique, or with the bulk structured allograft. If it is really there, suppose in some hospitals they have the bone bank, they can as well utilize this bulk allograft. Suppose if the epicondyles are totally absent in the femur, and so we need to have the rotating hinge platforms, that is the high constraint implants, which are there mostly available nowadays. So tibia. So in the femur we depend on the epicondyl's integrity. Here we depend on the tibial tuberosity integrity. So the management will be depending on the tibial tuberosity integrity. Supposing the tibial tuberosity is unaffected or not involved, and if the depth of the defect is less than 10 centimeters and it is mild metaphyseal bone loss only, we can as well manage with our cement, or cement with the screws, or impaction of bone grafting, or with the screws, along with the screws, or with metal augments. If it is more than 10 mm and significant metaphyseal bone loss, we need to go out with the metaphyseal sleeve or the cone technique, or the bulk structural allograft. If the tibial tuberosity is affected drastically, and again we need to go for the rotating hinge platform. So now, how to address the tibial bone defect, which is the most common thing we need to address in the severely varus deformities of the knees, that is severe osteoarthritis. So if it is less than 5 mm, we just can as well go out with the cement augmentation. If at all needed, the screw also we can as well place. if the area of clot affection is more than 25% or the component is unstable, we need to go with the metal augmentation. If the component is stable, we can as well get away by just doing the cementing or the bone grafting along with the screw. So this is the pictures showing the bone cementing technique, less than 5 mm defects, small central defects. And here we use the screw as a pillar, but the disadvantage is poor mechanical support. Cement can't be pressurized in a nice way, and laminations will happen in the cement, and cement does shrink at times. So sometimes there can be an end result of cantilever effect of the implant, that is tibial tray, or the tibial implant producing process requiring another infusion surgery at a later time in long-term basis. So it's the least desirable option whenever that is really required. So bone grafting and screw fixation. The advantages are you can as well avoid the custom-made prosthesis or custom implants. You can as well avoid cement fragmentation. Another advantage is subchondral bone can be preserved, and you can have the uniform cementing technique. The disadvantage is local bone is not that sufficiently available, and fitting of the bone into the defects is difficult at times, and incorporation of the bone graft is unpredictable. Sometimes bone